cascade in your vascular injuries. But they're both still there. Platelets going quickly, responding to the injury. They form that clot, but then and that's like short time, like seconds, right? That's happening. We talked about why. And then the chemical markers that allow them to go through their three phases, them being the platelets. And then for the coagulation cascade, you're depending on those clotting factors, right? Those coagulopathy factors that we talked about, which ones we looked at the diagram. Look at it again today. You don't have to memorize the whole diagram, thank goodness, but you do have to kind of remember what factors are affected by sort of major medications you're going to use. But that's longer term from the cascade for coagulation, and it's stronger, right? So you can kind of think of the platelets are going in quick, and they're just putting down sandbags, right, to stop water. But then the coagulopathy cascade is then going to come in and make that structure permanent, right? They're going to go in, not permanent, but make it stronger by cementing everything together. But they are working hand in hand. We just want to make sure we're all clear on that. So last couple of slides of path, and then we'll get into the drugs, the pharmacology, and we'll just kind of go through where they're acting. And just keep in mind what we're getting after with the medications, and then if we have too much of a good thing, how do we reverse it? And then also drug interactions, as always. So the goal today is to try to get through all of the remaining slides. So we'll go a little bit faster pace because we dove deep yesterday a little bit on the physiology. And so now we can kind of just drive, once you understand the physiology, what's going on with the platelets and with the coagulopathy cascade, then we could easily just say, well, this drug works here. This is why you use it. This is why you don't use it, and how they interact. So a couple of key points before we go right into the classes. Basically, we're going to be looking at bleeding disorders and thrombotic or clotting disorders. And so this is going to kind of frame the why, right, of the therapies that we're going to use before we get into them. Bleeding side, you'll have deficiency in your natural anticoagulants like protein C, protein S, and antithrombin 3. And then when they're low or dysfunctional, then patients bleed, basically from our body's own humoral anticoagulants. And if we have a problem with them, we're going to bleed out or bleed worse or not clot well. Clinically, we more often see them on the opposite end, deficiencies in the protein C and S, which is going to lead to thrombosis or clotting, right? The body can't properly down-regulate it. That's what we see more often. On the hypercoagulable side, we have DVTs, PEs, venous thromboembolisms. We're going to get into each of those. Strokes, and we'll talk about when we can use some medications and when we can't. And then basically that side of the house is going to be our pathological clot formation in different vascular beds, whether that be arteries or veins. So you're going to obviously need to know how to treat both. And this is going to basically frame our approach to what anticoagulants do by preventing the clot propagation. And then we talked a bit about antiplatelets, and we talked pretty in depth about aspirin and how it acts on the COX inhibitor side of the house. Alrighty. So Virchow's triad. You can kind of put things into buckets when we start talking about bleeding and coagulopathy disorders. So it's going to fall into one of three things, right? It's either going to be an endothelial injury, so it's inside, and we talked about how that can happen with a thrombus, for example, in an MI or a non-ST elevated MI. The number two side of the house there is stasis of blood flow. So blood's not flowing, it's pooling like a pond, right? Or hypercoagulability, meaning that coagulation cascade is firing too much, and so we're making too many clots. So things are going to fall into one of those three sides of the house, and every clot can kind of be put into one of those buckets. Endothelial, we talked a bit about it. Trauma, smoking, diabetes. I know I mentioned that in one of the lectures, how that can damage the inside of the vasculature, and atherosclerosis, like build up those plaques in the vessels. Stasis, we always hear about that, like after long flights, right? Risk of a DVT, you're sitting in one position for a long time. We get stasis, pooling of the blood, which could then form a thrombus or a clot, and then we have risk for throwing those into the lungs and it becoming a PE. Also, hypercoagulable states, cancer, very common that we talk about. Kind of the contraindications are, if it's safe, is pregnancy. That's going to be hypercoagulable state. Malignancy, like I said, cancer, or some medications, estrogen, for example. So basically, the triad, if you figure out what you're trying to treat, what's going on with the patients, and you put it into one of those buckets of the triad, then you're going to see what drug class do I want to focus on to treat the process. So is it anticoagulation? Do I need to reduce the stasis or the pooling of the blood? Or what part of the clotting cascade or the platelet activity, those three steps we talked about, do I want to go in and kind of disrupt with a medication? And kind of clinical pearl, every surgical patient is going to have at least one component off of this triad, right? So if you're having surgery, you're going to have something involved. And that's why a lot of times the prophylaxis for like venous thromboembolism is standard in preoperative medicine. Getting into the Pharm. So this is the management of clotting, starting with the anticoagulants. And we're going to kind of look at some major classes here. Injectables are unfractionated heparin or heparin, low molecular weight heparin, and those are both just derivatives of heparin, one being lower in molecular weight and one being unfractionated. So you just really know the name. You don't have to understand the science of the difference between low molecular weight and unfractionated heparin. But we will talk about the uses and kind of what distincts them in their medication class, where you can use one better and one's better or worse, depending on what issue in the Virchow's triad you're trying to treat, and also what monitoring is required or not required. So then we also have in the injectable class the fundaparinux, and we'll get into that. On the oral side, we have warfarin, which is a vitamin K antagonist, and we'll talk about that a little more in depth. You have some direct factor XA inhibitors, apixaban, rivaroxaban, and doxaban, and then you have the direct thrombin inhibitors, dabigatran. So you got to just kind of keep the drugs organized by, are they acting directly, indirectly, where in the coagulation cascade, and then are we talking injectables or oral, and what's their clinical use? Obviously, there are some injectables that patients can use at home for anticoagulation, but when we talk about heparin, a lot of times we're thinking more of hospital side of the house. And just remember, when we call anticoagulations, that's not disrupting clots. Like that's not the fibrinolytics or the thrombolytics, the clot busters. Anticoagulation are just what they're saying in the name. You're decreasing coagulation, but you're not busting clots, like we talked about the use of those in our STEMI patients yesterday, and the benefits of possibly using a thrombolytic or a fibrinolytic versus PCI, or what patients were kind of grouped into an area that we need to get the fibrinolytic on board if there's going to be a delayed or an extension of time to get to a PCI lab in that STEMI patient. But remember, just anticoagulants are clot propagation. We're decreasing clot propagation. We're not busting clots. No lysis, which we're going to talk about those, but at this moment with anticoagulations, they don't bust clots that are already there. So this is kind of a concept, right? What's your ideal anticoagulation? What could you use? What would be ideal? Perfectly, you would prevent, pathological clotting. You're going to then also want to preserve normal hemostasis. So if you're cut, you want to maintain your body's ability to cause a clot. Minimal bleeding, you would want that to be high on your priority list if you're designing the perfect anticoagulant, right? And then no monitoring, not going to labs, not trying to figure out, well, what's the INR, what's the APTT. So that would be a perfect world, but they don't exist, right? Closest thing we are going to talk about to that is a DOAC, or a direct oral anticoagulant. Anticoagulants as a class reduce thrombus expansion, and they prevent formation of new clots. We already talked about, if you look at virtuous triad, you can see all the different pathological conditions that we want to think about anticoagulation in based on one of those buckets that we're putting in, whether it's stasis or the other two kind of tiers. We already talked about the not busting clots. And then you kind of just look at risk-benefit for which anticoagulant you're going to use. I mean, what are we trying to get after? What's the worst thing that could happen, the best thing that can happen? What's lower risk, but we get the desired outcome or the desired benefit. That's how you're going to choose which anticoagulant route you're going to go. So this is the coagulation cascade, and then that's at the top. We talked about it briefly yesterday. And then there at the bottom, I'm talking on the right-hand side of the slide, that's where your antiplatelets come into play. And we talked about the three phases of the platelets. And so the bottom right are the medicines that we've actually already talked about. We talked about them in the STEMI patients. And when we're going to use dual antiplatelet therapy, we said it's going to be aspirin unless contraindicated, and then a medication from either the P2Y12 class or it's going to be from the GP2B3 alpha class, and we talked about that being the stronger of the two, and then the kind of the star representative of the P2Y12 class being that clopidogrel. Okay. Just remember kind of from this slide that the factor XA, that's that common gate. So blocking XA has broad effects on the coagulation system because you're talking from the two different pathways converging, and that's where that takes place. And as I mentioned, start the lecture, the antiplatelets and the anticoagulants, working on those two different mechanisms for clotting and thrombus formation, but in normal homeostasis, they're working together. And so we choose to disrupt based on whatever the clinical presentation is, either the platelet activity, which is normally happening more in arterial damage, or the normal coagulation, which is a lot of times more, we think, involved in venous. But we're choosing which of those two mechanisms that normally work in unison. When we need anticoagulation or antiplatelet activity, then we choose which route we're going. And then the rest of on the left are the intrinsic versus extrinsic pathways that we talked about, warfarin being in one and heparin being in the other, and then leading to the common pathway. And then that's the platelet activity down at the bottom. By no means do you need to memorize. I'm not going to ask all these steps. This is just kind of your understanding visually so that we say that heparin acts on these factors, warfarin acts on these factors, the DOACs acts on these factors, that you kind of know in that cascade where exactly that's taking place. And that's why we spent so much time discussing the physiology up front, so that now we can just say, where is this medicine targeting? And then that's just highlighting the ones that I would know for warfarin. The factors for warfarin, they're vitamin K dependent, and they are 2, 7, 9, 10, and I don't have a fancy fun way to memorize it, but I can tell you that it's always tested which factors in the coagulopathy or coagulation cascade is warfarin involved in limiting, and that is vitamin K dependent factors. So what does that mean? Warfarin blocks recycling of vitamin K, which are needed to activate the factors I just told you needed to know. So warfarin is blocking the vitamin K needed to activate those the different factors 2, 7, 9, and 10, and also it inhibits protein CNS, which we talked about very briefly, and that's about as much as you need to know about it. That's your body's normal anticoagulation system. So basically, you need to remember that warfarin has a delayed onset. It doesn't affect your circulating clotting factors. It only affects new factors because it's blocking the vitamin K dependent factors, the ones that have already been activated and out there floating around. Warfarin's doing nothing to them because it's just blocking their conversion because it's blocking the vitamin K, so you're not making new factors that we mentioned, the factors that we mentioned. And also remember that factor 7 is the shortest half-life. Factor 2 is the longest. When we're talking about warfarin use, and that comes into play, and we'll talk about why. It's because you have to bridge when you start a patient on warfarin, you have to bridge it with heparin. Because initially, paradoxically, when you add warfarin on, it's actually going to increase coagulability for a short amount of time. So heparin still has to be on board when you first initiate the warfarin to kind of counteract that reflex increase in coagulation in the beginning. So you'll always have a bridge because of how warfarin acts on those factors. You'll have a bridge with heparin as you move to warfarin. And then once you pull your labs, which we'll talk about what you're going to pull, and you see that you're in your therapeutic range for the warfarin, then the heparin can be stopped. Make sense? Bridge heparin with warfarin. So warfarin, you're looking at AFib, and then one of the other things I want you to kind of remember different from the other classes, or from the other classifications of your anticoagulants, is the prosthetic valves, especially the mechanical valves. That's warfarin. That's warfarin. When you have a patient with a prosthetic valve, especially mechanical ones, it's warfarin. And I think that was something I added to your slide deck on the DOAC chart for any of you that have seen it. We don't use DOACs. They're good in a lot of ways. Like I said, they almost hit all the criteria of a perfect anticoagulant that we discussed in our ideal world, but they don't work in mechanical prosthetic valves. Hypercoagulable states, you're going to want to use warfarin, i.e. you have a protein C or S deficiency. Post-MI, secondary prevention, warfarin. Long-term DVT, deep vein thrombosis on pulmonary embolism therapy, you're going to use your warfarin because the DOACs aren't hard enough. Mechanical valves, strict warfarin. Also, warfarin is the only option for patients that have severe renal failure that requires anticoagulation. These are kind of your caveats, and must use warfarin in those situations we just mentioned. Individualized warfarin, you don't need to know how many milligrams or anything like that at this point. You'll get that later in your clinical training. But it can take a week to actually hit your therapeutic doses. Adverse effects, bleeding, bruising, kind of a unique one is the skin necrosis. You can get some skin necrosis from warfarin therapy, and also the purple toe syndrome, which you can see the picture of the purple toe syndrome there. and that's from cholesterol microembolization. Right? You're getting some little tiny emboli down in the distal areas of your feet and your toes from cholesterol microembolizations. But purple toe syndrome is kind of unique to warfarin, whereas obviously you can get bleeding from any of the other anticoagulants and bruising when you decrease in the body's ability to coagulate. But those two are kind of unique. Pregnancy, it's contraindication all day, every day for warfarin. Tetratogenic, don't use it, absolute contraindication. So it's a lot of drug interactions with warfarin because it's protein bound. So any drug that's going to displace from albumin, any drug class or any drug action that displaces the albumin, is going to spike your warfarin and increase your bleeding risk. However, we know that we're going to monitor it on our patients on warfarin. And what are we monitoring? What's the lab for warfarin?
INR.
It's a winner, right? So INR, warfarin, INR. It's the winner. WINR, warfarin, INR. Don't need to know the numbers on the INR. So NSAIDs are going to elevate bleeding risk. We've talked about NSAIDs. They always elevate bleeding risk. So obviously if you have an anticoagulant on board, you need to be careful with NSAID concurrent use. Food interactions. We said that warfarin is what? For which of the factors, right? There's the vitamin K dependent factors that it's inhibiting. So if foods are very high in vitamin K, like your green leafies, it could reduce your INR. And just keep in mind that anything that's going to increase your vitamin K is going to decrease warfarin's action. But you'll see that on changes with the INR. This slide basically is telling you what I've already discussed, why warfarin is slow onset to get to the desired therapeutic level with your INR, and why you have to bridge. Because basically warfarin's effects are going to depend on the half-lives of those clotting factors. Remember, it doesn't do anything to the factors that are already formed using the vitamin K. It's just warfarin is going to keep from the new vitamin K factors from being activated. And we talked about which ones they were. You don't need to know the half-lives. Basically, you just need to know that anticoagulation is going to lag with warfarin, so you'll need the heparin bridge. We're talking about a week, right? 5 to 7 days. So this isn't your quick-acting anticoagulant, and that's why in the hospital, usually not warfarin. You'll start your bridge, but then you'll be discharged on warfarin. You're going to be using an IV, probably with heparin or one of the heparins inpatient. And I talked to you about the small window of hypercoagulable state caused by warfarin, and that's why we use the bridge. And that's also what can cause the skin necrosis and the purple toe. INR, that's what you need to know about the labs for warfarin. Usually every few days until you get to the therapeutic range, and if there's no main change, you're going to be once every 4 or 6 weeks, once every month, month and a half. You do not need to know the INRs for different disease processes, i.e. you don't need to know what the INR is for AFib, DDT, or PE. Just know that we're going to monitor it to a therapeutic range of the INR based on which condition in the Virchow's triad. If your INR was good, then it goes out of whack, start looking at other things if you do not change the dosage, right? New meds, did you simply now all of a sudden eat every green leafy vegetable at every meal, so your vitamin K is going up, but if your INR's been stable on your patient and there's a big change and you haven't changed their dosage or frequency, then we need to look at what else is going on. Alcohol use, acute illness, anything that may have changed in their system. All right, reversal. So for warfarin, it's vitamin K and prothrombin complex concentrate, PCC. So the vitamin K is going to restore the liver's ability to synthesize the clotting factors. Why? Because warfarin inhibits those clotting factors. So they're vitamin K dependent. So you add on the vitamin K, and we're going to reverse it, but it has to be both the vitamin K and the prothrombin complex concentrate, PCC. So PCC is basically an immediate replacement of the factors 2, 7, 9, and 10. You don't need to know the 4-factor PCC versus the 3-factor, i.e. the Kcentra versus the profamine. You just need to know PCC and vitamin K for reversal. Not every high INR is going to require a reversal. If it's asymptomatic INR, no major bleeding issues, you just hold the warfarin. And then the liver is going to be able to synthesize those factors once you hold the warfarin, as long as there's some vitamin K around. So you don't always have to reverse it, only if there's worrisome signs and symptoms. You can give the vitamin K orally for a predictable response. There is an IV vitamin K we'll talk about here in a second, but you can give it orally. There's a risk of an anaphylactoid reaction with the IV one though, so it just has to be infused very slowly. So vitamin K, physiological antidote. Onset depends on the liver synthesizing new factors, just like it takes about a week for the warfarin to get to INR. When you start reversing it, it is some time, but now we're looking at like hours, maybe a day. So the reversal with vitamin K, the phenidone is a little faster than the therapeutic INR level reached with warfarin. Route matters. PO is actually preferred for the vitamin K. IV is good, but it has to be given slowly. And we try to avoid at all costs the IM or sub-Q version of the vitamin K. Just remember, when am I going to use it to reverse it? It's only when I have a severe INR elevation or active bleeding, not just because the INR is a little bit higher than what our therapeutic range or goal was. I will not ask you numbers. If you give way too much vitamin K or give it inappropriately, you can kind of be out of your window to get warfarin back on board and starting anticoagulation again. That's just a clinical pearl, nothing's going to be able to test. Now we're moving to heparin. We're good on warfarin. All right, so injectable anticoagulants. Unfractionated heparin, I talked to you about, is just a different version that's synthesized of heparin. Basically, what does heparin do? It binds with antithrombin 3, accelerates its ability to inactivate thrombin 2A and factor XA. That's specifically unfractionated heparin. IV, almost immediately. So obviously, a lot more rapid anticoagulation effect than warfarin. Drug of choice for acute anticoagulation is the unfractionated heparin. It's not absorbed orally, so it's got to be IV or sub-Q. This one, UFH, is okay in pregnancy. It doesn't cross the placenta. So key difference between it and warfarin. Heparin's effect is kind of highly variable. So we're monitoring heparin with what? INR?
APT.
No, that's winter. Warfarin, INR. So APT2. This is for you visual folks, just how the unfractionated heparin is binding to those factors that we mentioned. Adverse effects of unfractionated heparin. HIT, heparin-induced thrombocytopenia. HIT, know it. You have to know HIT. It's an immunological reaction that causes platelet activation and paradoxical thrombosis, which is pretty much the opposite of what we're trying to do with an anticoagulant. So you have thrombocytopenia, however, you're still clotting. So your platelet count's going to drop by like 50%, but then you're going to have adverse clotting as well. So it's paradoxical. If you get hit, if you see the 50% drop in the platelets after unfractionated heparin, then you're going to stop anything with heparin in it. And there's a lot of things in the hospital that have heparin flushes. So anything that involves heparin, no matter what the agent is, if heparin's in it, you stop it when you have hit. And then you're going to go to a direct thrombin inhibitor, i.e. argitroban, which you can use in HIT. And we'll hit that class a little bit later. Other adverse effects of the unfractionated heparin, osteoporosis with chronic use and hyperkalemia. The HIT is the big thing that is usually the biggest concern for adverse effects. You never give anything with heparin, again, to any patient who's had HIT. So no heparin-coated device that you're putting in the body, i.e. those stents or things that we talked about. Anything with heparin on it is a no-go if you've ever had HIT. Contraindicated that patient forever. So heparin flushes, low molecular weight heparin, that other type of heparin that we talked about, you can't use it either if the patient's ever had HIT. Indications, obviously you're not going to give an anticoagulant if there's active bleeding. Severe thrombocytopenia. We just said that HIT is a major adverse effect. And so if we start to drop those platelets way down, we're going to use the other medication that I mentioned and never use heparin again. Any history of HIT or current HIT, no go for heparin. Unfractionated, or any type. Intracranial hemorrhage, obviously if you have a bleed in your brain, you don't want to make more bleeding. You don't want to use your unfractionated heparin in that case. So if we talk about HIT, the major adverse reaction for all the heparins, unfractionated is the worst culprit. Then low molecular weight, a little bit less. And then that other injectable heparin we were talking about, fundaparinux, or the other injectable in that class, anticoagulation, its off-label use in HIT is actually okay. That's the lowest kind of cause or medication that causes HIT. Much lower with the fundaparinux, and then the low molecular weight, a little more, and then UFH, the highest rate of HIT. As I mentioned, be careful because there's heparin in a lot of things and they're in a lot of multiple concentrations. So dosing sometimes can be a big error that's made. And there's just some examples there on the bottom of the slide and all the different forms that heparin can come in. So you have to be very cautious about your dosing and your concentrations, because if you're given the wrong dosing or the wrong concentration at too high of a level, then you're going to get those adverse effects that we spoke of. And then I told you about the HIT risk and never using anything that is in the heparin class of medications again for any patient who's ever had HIT. usually given as a bolus. You won't be tested on that in this arena, and not in Pharm, but it's something that you're gonna need to know as you move through with your clinical training. You don't need to know the actual dosage. I put them there just for your essay, but you will not be asked at this point in your training what the dosage is for the heparin. And as I said, this is probably going to be in the hospital. The therapeutic range, I don't need you to know. I just need you to know that when you're monitoring the unfractionated heparin, we're using what? APTT, not INR, which is warfarin. Obviously, you're going to always, when you're given an anticoagulant, you're going to get some blood. Also look at the platelets, hemoglobin, hematocrit, and you're checking your patient for any signs of bleeding, all the adverse effects of using the medication. So now we're talking about a lower molecular weight heparins, just another version, which obviously by the name has a lower molecular weight than heparin. It's derived directly from heparin, but it's manufactured to have a lower molecular weight. This primarily inhibits factor XA. And if you go back to that schematic of the coagulation cascade, and if you remember where I talked about the extrinsic and intrinsic forming that common pathway, it's at XA. So this is the low molecular weight is primarily inhibiting that factor, the same as or a lot of our direct oral anticoagulants will hit in the next hour. The low molecular weight heparins, it's kind of more predictable with their pharmacokinetics. So you can use fixed weight dosing for these patients, for patients that you put on low molecular weight heparin versus what we talked about with the unfractionated. A lot of times, a low molecular weight is going to be preferred for pregnancy and for most of the clinical indications. Advantages, I mentioned it. The unfractionated is going to be your highest culprit in hit, so less chances of hit with the low molecular weight heparin. More predictable dose response, so you can kind of predict more what's going to happen based on what you give, based on weight with the low molecular weight. And it has a longer half-life, so less frequent dosing. Because you can also use the low molecular weight outpatient versus just in the hospital. If you're going to keep them on that versus warfarin, and we talked about with warfarin, kind of what some of the side effects were and how that had to be monitored and how often. No APTT is required for the low molecular weight. However, there are some situations where you may want to monitor the factor XA. We talked about it briefly yesterday, but those special situations would be pregnancy, right? Severe renal disease. So you may want to actually look at your factor XA to monitor patients on low molecular weight heparin, but it's not required. It's one of the benefits is that it's not required to do any kind of lab draws to look at the therapeutic range for your factor XA. Pregnancy, obesity, renal impairment, and kiddos, pediatrics. That's when you might want to actually draw the anti-XA level for monitoring. Enoxaparin, Levinox, that's your kind of standout in the low molecular weight heparin class. Major clinical advantage because it's predictable, and that's what we mentioned. They are usually given once or twice a day, depending on the indication, so less frequent dosing. It doesn't have to be a constant IV drip when you're in the hospital. For VTE, or venous thromboembolism prophylaxis, fixed low dose regimens are used, which are good. We've been saying for the last 2 weeks, start low, go slow. So if you use a lower dose of anything, then your risk of getting the side effects are less. Unnecessary, as I mentioned, for monitoring the APTT, for low molecular weight heparin, but if you need to, you can pull in those special situations the anti-XA level, and those are going to be based specifically on which medication that you're looking at. And we'll talk that more in the DOACs, that you can actually pull the anti-XA, but it's got to be by which drug in the direct oral anticoagulant choices that you're using. It's not just a lab level of anti-XA, it's anti-XA based on the actual medication that you're using. Remember that low molecular weight heparin is going to be your drug of choice for anticoagulation in your pregnant patients. They don't cross the placenta, lower risk of hit, and so you're going to use them preferably in pregnancy over the unfractionated. Bless you. This basically is a highlight of why low molecular weight heparin has replaced unfractionated or heparin in many outpatient and inpatient scenarios. And we mentioned all of these already. You do have to be careful with low molecular weight heparin with chronic renal disease. It's the same numbers that we're looking at for our hydrochlorothiazides, actually. If your creatinine clearance is less than 30, then 30 milliliters per minute, then you're going to use unfractionated, so low molecular weight. Protamine sulfate, so within minutes, it works rapidly to reverse or inhibit the action of the heparin on board. You don't need to know the dosage, you just need to know it's a reversal agent. Stop the heparin, then give the protamine. The protamine does not 100% reverse the low molecular weight heparin. It's only getting to about 60% of a reversal action. There is no complete antidote. Protamine is the best thing we got, but there is no 100% antidote for the low molecular weight heparin. You usually give the protamine very slowly, over like 10 minutes. I'm not going to ask you that on the test, but we'll obviously be utilizing that when you're doing your rotations in the hospitals or your phase 2s. So it's something to keep in mind, and that it's a slow infusion. Okay, so we're moving on from the heparin class into the third injectable that we're discussing, the fundaparinix. So it binds to anti-thrombin 3, and it selectively inhibits the same factor as the low molecular weight, that XA, factor XA. It does not significantly inhibit thrombin 2A, which that's what makes it different from the two heparins. The unfractionated and low molecular weight is that fundaparinix does not inhibit thrombin or factor 2A. It's given sub-Q and no monitoring here as well. A lot of times you'll see this used for DVT prophylaxis or after orthopedic or abdominal surgeries. And often in treatment for an acute DVT or PE, combined with other anticoagulants like warfarin in that situation. Very low hit risk for fundaparinix. So we mentioned in the scale of least likely to very high likelihood, it's the lowest, right? And actually, fundaparinix is used off-label for patients who develop HIT often. So most common adverse effect, like any of the anticoagulants, bleeding. There is a major black box warning for utilizing the fundaparinix for spinal or epidural hematomas. If the patient has those, that's contraindicated use for the fundaparinix. Severe renal disease is contraindicated on thrombocytopenia as well. Can be used in pregnancy if clearly needed, and it's not 100%, does not cause HIT. It still can. So for your pregnant patients, you're still going to look at risk, benefits, and why we're having to get them on an anticoagulant. But there is a smaller risk of HIT, but that does not mean it's an absolute 0% chance. And with fundaparinix, there's no reversal agent. Once it's on board, it has to reach its half-life, and you cannot reverse it. Okay? Anybody, everybody? Somebody tell me.
D. APTT.
Different. Yeah, we got APTT. Moving on down the chain, now we're going into the direct factor XA inhibitors after we take a 10-minute.
I'm going to Vegas this weekend. It was you. I was trying to figure out what was in between them. Oh, you didn't know mine. Dude, it was fun. No, I like where every other thing forward. And then the stacking. Dude, the stacking is the right way. First time I saw that, but it doesn't mean I like getting it. Exclamation, you read it quick, you're like, wait. And then his next one's right.
I mean, if you eat right away, I
There was like 5 houses, like kettle mix, like we were on like Zillow and all these different like and like scheduling like tours and stuff, and we get there, and it was like basically a catfish because it showed like a nice house on it, and then there,
Oh,
and it's not the same house.
did you already sign up? And like,
I didn't sound great. I was like 2, and like some guys you get there, you send like a code, and you get into the house. So like a couple houses I got there, I'm like, oh, this ain't what they show. I found like multiple posts of the same like stock house. So I'm like, yeah, there was one house I got there, and they both were open because like it was a code through the lock of the deadbolt on. So I thought I I just couldn't get in, and they were trying to make me do a whole workaround just to be able to see it. I was like,
Why did you guys stress out?
instead of saying,
What did you guys stress out?
instead of buying my house, well, one,
oh, you bought that?
I didn't buy it.
No, because
Well, that's not.
Oh, yeah, because you have to drive out. You have to like pass by. Oh, yeah. No.
yeah, I got your. I don't have that Jackson. So I just wouldn't have
35, so if you take the legs down to the 90, and then you just take the 90 all the way down, and exit right after that on the drive right next to the
You only have to take 35 going there, but you don't take 35.
No, I do. It's both ways.
35 get traffic.
It does, so like with 35, I get like 35 traffic, and I get 37, I go 37, the back end of 90. So like 35 foot quicker, or like how it's just, it like cuts like diagonally across, it goes out to like the turn 90, but like 37. So you don't get if that's like terrible, backwards on that, I can go out to the reflector and go up 410 and just go all the way around. Like, that's what like that's
I'll take 30 minutes to drive. Yeah, because I like 30-minute drive. I kind of just like
Yeah, that's on the one. I did the math.
that's the one thing that's
Yeah, we don't have those
literally just like on Google Maps trying to find like neighborhoods where I can just like take side streets.
yeah, which is why I have so we didn't really get to I tried to get my house before 6:30 because like the horse is traffic.
6:30 is like your time. Like, I gotta be ready.
Yeah, I believe after that, I know traffic, it would be as bad. Like, if I leave, I put that at 7:50, and after that, I get 7:35. But I know by 8 o'clock, we're going to especially with all the and we can do about that.
That's the whole that job.
They're hard to get. You did bow in the back of the room so fast. I thought you would appreciate it. I was looking to see if I could like kind of order it. Usually I never see it. If they say, I don't feel a lot of things. Yeah. I'm actually having a lunch. I'm actually yesterday.
Yeah, exactly.
Did not. Yeah, I might have to have one day. Then I have one again. Maybe I won't, so I can have like 3 weeks. I thought this was gonna do anything. I'm just gonna burn my fucking hand. So I just tried to. More passionately.
Oh my God.
Passion, you know, and you gotta be on your toes. You're gonna get a question in your way. I gotta be like always studying. Which is hard. Yeah. No, everyone engaged. Everyone's definitely looking ahead to see like where the questions go. Yeah.
Because it's a large group, they might be considered. It sounds a lot, but if you want to get 2 slices per person, if everyone gets 3 slices, it's not even 3.9. Yeah, so that'd be
Let's go ahead and get started back. Rock and rolling here. We'll get as far as we can get in this last hour. I'll hit the high points. You'll have this 4-day break to look at this. And then Tuesday, no matter how far along we get today, Tuesday we may have 5-10 minutes to talk about anything we don't hit today. Any questions about hematologic agents, and then we will do a review Tuesday. As you're studying, when people ask me questions, if I think it's applicable to the whole group, I want to put it out. So the memory jogs slides, which I'll post these tonight or today when we're done. They're a good way to anchor your studying. You're in the fight if you know what's on the memory jog slides. You're in the fight, but that doesn't mean that that's everything, right? That's not everything there, but it's to anchor you. If you think about the concepts that are on the memory jogs, then that should kind of lead you down the path of what else may be testable. And then the questions that we're going to ask, right? I know we spend a lot of time, or have spent in Block 1, talking about some of the pharmacokinetics, the pathophys. Those are all to make sure you understand the background of where these medications are working and activated. But as I mentioned, we're moving into clinical thought processes, right? So the check on learning 4 or 5 that I put after each lecture, They should kind of drive how you think you're going to see the questions on the exam, and also kind of, if you understand what the question's asking and why it's the right answer, those four other choices have why they're incorrect there. So that would imply that if you know why the wrong answers are wrong and the right answer is right, that you kind of guide your studying that way as well. Other than that, we're just going to cruise through here and see how far we get, and then I'll hang around for a few minutes as we hit the lunch hour. If anybody has any burning questions, then I'll talk to you Tuesday with finishing this up, any questions, and moving into kind of a high-level review, outline type review for the test, and then you'll have a nice long, 5-6 days between Tuesday and the test the next Monday. So should have ample time to kind of own this material. So as far as anticoagulants go, moving on down, getting into the direct thrombin inhibitors. They act directly on thrombin, which makes it different from the heparins, right? That's going to inhibit the ability for fibrinogen to be turned into fibrin, which is what's going to kind of stabilize that clot. The agents are listed there, I think, on the slide. If not, it's on the next slide. But they're developing argatroban, and then the oral agent is dabigatran. So the first two are parental, the developing and that argatroban, and there's a chart on it further in the slide deck. And then dabigatran, you should know, is an oral agent. They're important in hit management. They inhibit both free and clot-bound thrombin. So that's mechanistically different than we talked about with the heparins, right? Which indirectly are going to inhibit it. But the DTIs, as the name mentions, they bind directly to thrombin, which is factor 2A. Prevents conversion of fibrinogen to fibrin. So you need to know the mechanism. Yes?
Did we skip direct factor XA inhibitors, or is that just a little bit later in your slide deck?
No, we hit them. Did we not? Okay, did I jump too far forward? Okay, we'll hit that real quick. It's not a couple of slides. Okay, so thank you for pointing that out. As the name mentions, with the direct oral factor inhibitors, they inhibit XA, right? They directly block XA without needing antithrombin 3. Same black box warning that we mentioned earlier. Spinal and epidural hematomas. There are no-go with the direct oral factor XA inhibitors, which is the same as low molecular weight heparins and fundoparinics when it comes to that black box warning for spinal and epidural hematomas. Do not stop these medications, the direct oral factor XA inhibitors, without some alternative anticoagulation on board, or else you're increasing the risk of the things that you're trying to get after. Increased risk of stroke, particularly in your AFib patients. So the advantages of the direct oral anticoagulants over warfarin: a lot fewer interactions, no routine monitoring, but they're expensive. And the reason I thought that I mentioned because that we talked about them, because I mentioned this point that they are not used in prosthetic valves. That's what do you use for anticoagulation with prosthetic valves? Warfarin. So DOACs, we mentioned as being almost the perfect anticoagulant, but not in prosthetic valves. And they're not great because they're not cheap, they're expensive. And actually, you have to avoid this medication with the prosthetic valves. They have really become the first line therapy for non-valvular AFib and venous thromboembolism for most patients. And there they are listed for you. We mentioned that you can monitor anti-XA with a lab. You can monitor it, but it's based on which DOAC that the patient's on. And we said we could also monitor it in those special situations you might want to. But their selling point is it's not required for the DOACs, and the medications are listed there. Not required, but we talked about pregnancy, kidney disease, kiddos, right? You can, if there's an indication or a concern for those special populations. Let me just go back one, make sure I hit everything there. Yep, I just want to make sure you saw where they're hidden right there on XA. That's one of their direct factor XA inhibitor. We good on the DOACs? And, okay, here's where we're on thrombin, or the direct thrombin inhibitors. Directly to thrombin factor 2A. Mimic conversion of fibrinogen to fibrin. That is very powerful in this class, right? Because thrombin is the central enzyme of the entire clotting cascade. If you inhibit thrombin directly, you shut down multiple downstream effects. You can always look back at your clotting cascade slide, that monster with all the different pathways, intrinsic, extrinsic, the cascade, and then the platelets. But you can look at where thrombin is in that cascade and notice how it differs from heparin, which indirectly inhibits thrombin by enhancing that antithrombin 3, whereas the direct thrombin inhibitors do what their name is. DTIs independently will bind thrombin. They don't need a cofactor. And we talked about inhibit both free and clot bound. So it works better in acute situations, and it works during HIT, and they're useful in the PCI lab, right? The cardiac cath lab. And here is the slide just talking about both of the medications, basically a chart of, or a table of what we just discussed. Dabigatran. It's the only oral direct thrombin inhibitor. So prodrug, that when you take it, it converts to its active form once it's absorbed. You're going to use it for preventing stroke, systemic embolisms, and non-valvular atrial fib. So if it's AFib not caused by a valve issue, you're going to think the oral version of the direct thrombin inhibitor, which is dabigatran. Used for treatment and secondary prevention of DVT and PE, and for recurrence of DVT and PE to ward off the recurrence. 5 to 10 days of parental anticoagulation before you switch to dabigatran for a venous thromboembolism. Unlike warfarin, the dabigatran has predictable pharmacokinetics, but it does require twice a day dosing. You're cautious with this medication in your elderly and with low body weight. And with, as in all the medications, bleeding risk and renal insufficiency. Any renal insufficiency is going to lead you to an increased bleeding risk, which all these medications are obviously anticoagulants. So with decreased renal function, you are careful, and with all of the medications, cautious of the possible increased bleeding risk due to that decreased kidney function. The interactions for dabigatran is primarily P-glycoprotein, which is PGP transport, and that is comes with a risk of drug interactions, right? Verapamil, amiodarone, ketoconazole, so clarithromycin. One interesting thing or special caveat about dabigatran is that the absorption is decreased with antacids. So that's something you just need to be careful of. Usually you just tell your patient 2 hours between those two medicines, right? Between antacid and your dabigatran. Adverse effects, bleeding, dyspepsia, GI upset. So this one kind of, this medication, it is PO, so you think it's the only direct thrombin inhibitor that is PO, and because you're taking it orally, you can have GI side effects in dyspepsia. Don't use it in mechanical valves, because that's warfarin. Don't use it in severe renal failure, and we mentioned why. Don't be careful or cautious with other medications that I just gave you a little list there. The PGP inhibitors, kind of like our same thing for our CYP3A4s. But if your patient is on another medication that's an inhibitor of PGP, that's another caution. And I mentioned briefly what they were on the last slide. Pregnancy, don't use it. There's not enough data to say it's okay. No monitoring, but you might want to get a BU and creatinine and monitor. No direct coagulation monitoring or anticoagulation monitoring, but you might want to pull still your BU and your creatinine and just make sure that the kidneys are functioning okay. Because it's heavily eliminated through the kidneys. So it's heavily eliminated renally. So with this medication, the renal function is higher on the list of cautions. Interesting clinical pearl about the dabigatran. It's got to be in its original packaging. Once you open it, the container expires in 4 months. So just like we have to worry about our 6-month timeline on our fast-acting nitrates, with dabigatran, you got 4 months. It's very sensitive to moisture. That's not testable with clinical awareness. And there's the dosing, and we talked about some of the advantages and the disadvantages. All right. So now we're moving into idacruzumab. So Praxbind is easier to say, right? It's IV. And what is it used for? It reverses the dabigatran. So this is a reversal agent. You don't need to know it, but it's a humanized monoclonal antibody fragment. So what it's going to do is bind to the dabigatran stronger than thrombin does, because we said dabigatran is a direct thrombin inhibitor. So basically, this medication via IV is going to competitively compete with the thrombin, and it has a higher affinity than the thrombin does for the dabigatran. Works immediately. It's life-saving if you have life-threatening bleeding, urgent surgery, uncontrolled dabigatran-associated hemorrhage. When I say urgent surgery, your patient's on dabigatran and they have to have an emergency surgery. You can put this on, it acts immediately. Well, you can give it IV, it acts immediately, and then they're safe to proceed to surgery. Obviously, if you have uncontrolled dabigatran-associated hemorrhage, because it can cause a lot of hemorrhage being a direct thrombin inhibitor, then you can put the Praxbind on board quickly and immediately kind of reverse that. It costs a lot, but it is a complete reversal for the dabigatran. Important point, right? It reverses dabigatran, but not all the XA inhibitors. Only dabigatran. Dabigatran. That's the only one. The only direct XA inhibitor that it reverses. And there's a chart, and this is just rolling up all of the anticoagulants with their reversal agents. How we know that? All right, check on learning. Mechanism of action of rivaroxaban. Rivaroxaban. What we got? Right. And then we'd probably need to know the other, why the other answers are wrong, and what the XA inhibitors versus the 2A adaptogenic versus warfarin and TPA, which we're going to get to. What about the second question? Hmm?
No monitoring.
None, yep, none. Okay, and the last question there. Yep. Bivalirudin, Angiomax. Heparin's also used, but the bivalirudin is specially approved for PCI preferred for HIT. All right, now we're back down in the coagulation map. Just to highlight, I mentioned earlier, the arterial events like your ACS or stroke and your peripheral artery disease, we're thinking platelet activity. There is some anticoagulation activity, but we think more platelet in artery events like an ACS or stroke. Venous events, deep vein thrombosis, pulmonary embolism, we're thinking anticoagulants. And then for active severe thrombus needing dissolution or dissolving is the fibrinolytics. The fibrinolytics are the class that bust the clots. Fibrinolytics / thrombolytics. Which that one chick on learning wasn't fair because you haven't had that class in depth yet, but we're going to talk about it now. Well, it would have been fair because if you hadn't seen something as an answer choice on the test on a week from Tuesday, then it's the wrong answer choice. If I haven't spoke about it, then it's certainly not going to be the right answer. Try not to do that to you, but if you see something foreign, well, if you haven't studied it, it's not going to be the right answer. Okay. Thrombolytics / fibrolytics. The only medication that dissolve existing clots. Anticoagulants, antiplatelets, just they work on coagulation and platelet activity. If you have a clot that needs busting, you're going to use a fibrinolytic, also known as a thrombolytic. They convert plasminogen to plasmin, which then degrades fibrin, so it degrades the cement that's holding the clot together. You're going to use it, as we've already talked about, sometimes in STEMIs. We talked about when you would use it if you had a prolonged door to cath lab time. Specifically, the timeline on that too is when the PCI is unavailable for 120 minutes, right? Acute ischemic stroke within 3 to 4 hours from the last time the patient was known well. You'll get more to that when you get into the learning about stroke. Massive PE with instability, you need a fibrinolytic. You got a giant clot in your lungs. Occluded central lines, you're going to look at busting that clot. So thrombolytics are going to increase your local platelet aggregation as the fibrin then dissolves the clot. This is why they're always paired with an antiplatelet or an anticoagulant, because your platelet activity aggregation is going to go up, and then the thrombolytic is going to work on the, dissolving that fibrin. But if you throw on the antiplatelet with an anticoagulation, then you're going to not allow the platelet activity to interfere with the lysis of the clot. So you're going to always see the antiplatelet used with a thrombolytic. So we're going to talk about the specific ones, TPAs, the big one you need to know, tissue plasminogen activation, or TPA. They activate plasminogen only when it's bound to fibrin. So once plasminogen is bound to the fibrin, then that's when it's going to do its action to dissolve the clot. Because that basically becomes a targeted clot for the TPA to work on. The main agent is alteplase, TPA, that's human recombinant TPA, and then tenecteplase is TNKase. It's an engineered variant, right? But it has a longer half-life than the alteplase. That means it can be given in a single bolus, the tenecteplase, which is very important for your pre-hospital STEMI care, like we talked about. So indication of the tenecteplase or the thrombolytics, we talk STEMI stroke, acute ischemic stroke specifically, catheter clearance, those type of things. Tenecteplase has fewer non-cerebral bleeding complications compared to alteplase. So a lot of modern STEMI protocols, you're going to see the tenecteplase kind of moving more in favor in the PCIs than alteplase. Okay, do not use it in non-ST elevation MI. Bottom right, fibrinolytics, thrombolytics, non-STEMI, don't use it. This slide just further iterates when you would not use a fibrinolytic. Obviously, if you're bleeding, you don't want to bust those clots. Cerebral vascular lesions, there's some specifics there. Ischemic stroke, less than 3 months. If you're given a thrombolytic or a fibrinolytic, you're going to have this card. You're going to have something posted, and you're looking, and that patient is being screened specifically for a thrombolytic. And if there's a contraindication on this list, you absolutely do not give it. There are a few be awares and be cautious, but there's quite a few of absolute contraindications. So you just have to be aware of what they are. The big ones would be bleeding, hemorrhage. 3 months ago, less than 3 months, you had a stroke, a head injury. Obviously, active bleeding, you're not going to want to give clot busters. Major surgery within 3 weeks, so there's relative contraindications, but the big ones are the absolute on top. Okay, so we just talked about it, right? Which of the following patients should not receive alteplase, TPA? None of them, yeah, so none of them should, right? And you can go back and refer to the chart, but every one of those are a contraindication, some of them being absolute and some of them being relative. But the GI bleed's an absolute. The stroke 2 months ago, that's within the 3 months contraindication. Intracranial hemorrhage ever is an absolute contraindication. And then the concussion, it's not absolute, but it was only 2 months ago. So if it was associated with a hemorrhage, you still need to be concerned. But I think that it shows it as 3 months is your relative contraindication on the chart. 3 month window for prior stroke, that's important. I would know that. To give TPA, that 3 month window. Moving into antiplatelets, which we hit it in STEMI, and we talked about aspirin yesterday. So we're going to fly through antiplatelets again. So here's your drug classes, and we talked about aspirin being a COX inhibitor, and then the other medications and what class they fall in, the other antiplatelets, pyridinol. There's a combination with aspirin, the PDE3 inhibitor, cilostazol. We talked about the P2Y12 inhibitors, the kind of star of that show being clopidogrel, and that when you're doing your dual antiplatelet therapy post-STEMI, you're going to give them their aspirin, and the dual portion is you're going to give them some antiplatelet, either the P2Y12 clopidogrel or the GP2B3A inhibitors, which we're going to use if they're going to the cath lab, right? Stronger indication for that stronger antiplatelet, the GP2B3 alpha inhibitors. So aspirin with one of those two antiplatelets. If they're going to the cath lab, you want to use the stronger one, the GP2B3 alpha. And remember, the arterial events are going to be platelet driven, and the venous events are going to be more fibrin driven, which are more in the anticoagulants versus antiplatelets. So arterial events, kind of like that in-depth discussion we went through at the very beginning yesterday of this lecture, when there's damage to the inside of the artery, collagen is exposed, and that's what gets that first A in the platelet activity going, right? Adhesion. And then there's your ADP-P2Y12 receptor inhibitors. And like I said, clopidogrel is the main one you get to see is the standout gold standard in that class. And there's a slide just rolling up what we discussed already about the glycoprotein 2B3 alpha inhibitors. And you'll need to know those two medications, obviously be able to pick them out of the lineup in that class. If you know, if you see the name of the drug, then you know what it's doing, because they're obviously inhibiting glycoprotein 2B and 3 alpha antiplatelet activity. And we could reach back to yesterday and remember antiplatelets are going to interfere with that platelet cascade from endothelial injury from the three different phases, right? That adhering, then they're activated, and then they aggregate, bring in all their friends. And then after that, which happens in moments, then we get our coagulation cascade is going to strengthen that and take a little bit longer. And with that, to make the plug that the platelets made stronger to reinforce it, that's when you're using fibrin from our factors. And then we talked about the different agents that were anticoagulants based on which factor and which pathway they're in. The P2Y12 inhibitors, there's your chart. We've talked about them. No clopidogrel. Clopidogrel is going to be your standout, usually by name. And then you know what they do. The inhibition of the binding of the adenosine bisphosphate ADP to P2Y12 receptor, but knowing it's a P2Y12 receptor inhibitor gives you the biggest clue. And we talked about some of the uses. And I'm not sure why that slide got wonky. I will fix that before I repost it so we can read what's over on the left-hand side. But we've talked about all these can increase bleeding risk because of its antiplatelet activity, or if you have any kind of anticoagulant on board. So the other antiplatelet therapies, we talked about aspirin quite a bit yesterday. It's working in that COX pathway. We had the slide that showed where it's working on the COX-1, and the key takeaway with that is that as far as inhibiting the COX pathway in the platelet, is that a week, a day, or forever? Forever, right? That platelet no longer can go down the COX pathway because it's forever blocked with aspirin, and then you have to wait on new platelets. So that's why when you stop aspirin, you've got that 10 days before you have platelet death, before the new platelets actually can function in the COX pathway. Aspirin, 81 milligram daily standard for secondary prevention of ACS. The 325, usually we use that acutely. We have them chew it. We don't use the enteric coated for our acute coronary syndrome patients. Remember, we were talking the MONA. So 325 chewed is usually the gold standard there. We're also going to use the aspirin for MIs, as I mentioned, stroke prevention, post-cath lab, because it's going to be dual antiplatelet therapy, right? Secondary prevention, that's back in favor for atherosclerotic cardiovascular disease. the big task force that looks at preventive medicine, and I think that might be the next slide or a couple. But basically, are by age group, risk stratifying, should we use aspirin or not use aspirin? But for certain age groups, it's still should use for ASCVD, secondary prevention. PAD, peripheral artery disease, we'll still use aspirin for. The enteric-coated aspirin doesn't significantly reduce GI bleeds, and it's not recommended for ACS. Use the chewable stuff in emergencies. And there's the slide I was referring to in that Cox pathway, and where aspirin is specifically active. And those are all the things that we've discussed in the past, why it's used, immediate release versus the capsule. But like I said, you want to do that 325 chewable for ACS. And here's the clinical summary of that U.S. Preventive Medicine Task Force, and they give you some age stratification is when should you continue to use aspirin to prevent cardiovascular disease for primary prevention. And there's the age groups with is a yes or a no. And the take-home point is it's an individual patient discussion, right? You as a provider talk to the patient in that recommended class of individually based on everything else that's going on with you. Is this recommended, not recommended? So just know it can be used as a primary prevention for ASCVD. Major adverse effects is from that inhibition of the COX-1 in the GI tract. We all talked about aspirin, how it affects the GI tract. Normally, the COX-1 is going to help generate prostaglandins that protect your gastric mucosa. So if you're inhibiting COX-1 with aspirin, that means there's less protection prostaglandins in the GI tract. And so that's why a major adverse effect is going to be on the GI tract, i.e. an ulceration, a GI bleed, dyspepsia, and we'll get to talk more in depth on that in a couple of weeks when we start GI Pharm. I'm sorry, when we start GI Pharm for the sophomores and teaching as well. But when we start GI for you guys. Rye syndrome in children for a viral illness. That's going to come up on almost everything for aspirin. Be cautious or causing Rye syndrome with aspirin in children that have a viral illness. That's very testable on a lot of the standardized exams. Pregnancy can cause premature closure of the ductus arteriosus. So that's a major adverse effect of aspirin. Any child with flu-like symptoms or varicella illness, don't give them aspirin because of Rye syndrome. That's the take-home point of that. And I just mentioned all of these. And then there's hypersensitivity, and we're talking about aspirin allergy, hypersensitivity, and then for surgery, the antidote, you may have to do a platelet transfusion and stop aspirin therapy 10 days before because of that irreversible binding in the COX-1 pathway for the platelets. So that's why you're stopping your medication 7 to 10 days so that those platelets you have on board when you go under the knife are not inhibited by the irreversible binding of the aspirin to the COX-1 pathway. And we talked about that may cause premature closure of the ductus arteriosus. That's an adverse effect with aspirin. Okay, so we're moving on to dipyridamole. Okay, so persimentine, it's either given PO or IV, and it stimulates prostacyclin synthesis, and it blocks cellular adenosine uptake So what does that do? It increases your CAMP in platelets. Decreases platelet aggregation. So that's why it's in the class of other antiplatelet. It decreases aggregation by those two actions, which I won't test you on the mechanism, just know it's another antiplatelet that decreases platelet aggregation. It's very weak as an antiplatelet in monotherapy, but it is combined with aspirin for secondary stroke prevention. And that's usually where we're going to see dipyridamole. You can read it, you can probably pronounce it better than me, but just know it's combined with aspirin for secondary stroke prevention. They use it, you'll see it used in cardiac stress testing as well, in IV. You can must avoid it in unstable angina. There's a syndrome called coronary steal syndrome due to vasodilation of healthy vessels that reduces blood flow to the disease segments. So just avoid it in unstable angina. You don't need to know about coronary steal syndrome, but you avoid dipyridamole in unstable angina. Adverse effects are mild: headache, flushing, dizziness. More serious would be worsening myocardial ischemia from that coronary steal, and that's why we said in ACS you don't use it. It does increase the levels of adenosine, and it could worsen MG, myasthenia gravis, by counteracting cholinesterase inhibitors, which now we're reaching back into some of those anticholinergics and cholinergic medications that you've already been tested on last semester. No washout, no antidote, but a washout is sufficient. So basically, Agrinox is what you're going to see, the brand name, aspirin and dipyridamole. It's not the same as taking these two medications separately. You're going to see it in a combo pill for its activity. And that's because it's of the extended release version of the dipyridamole versus the fast-acting IV version of the med. So this is just more about that combination. Secondary prevention of stroke is the take home here. And then we talked about the pathways, the dipyridamole increasing the prostacyclin, and the aspirin irreversibly inhibiting the COX-1, which decreases the thromboxane to A2, decreasing the platelet activation. Use it in the fixed dose combo. Don't interchange. Don't say, oh, I'll give the dipyridamole and the aspirin. It has to be in the combination of Agrinox. Twice a day dosing. Moisture is going to break it down. You have an increased bleeding risk with Agrinox and anticoagulants, which pretty much makes sense. And we talked about its effect on adenosine, so you can have an increased adenosine effects from it. Okay, now we're going to talk about another other category of the antiplatelet. Tilostazol is a PDE3 inhibitor, increasing the intracellular CAMP in platelets and smooth muscle. So basically, you're going to get reversible inhibition of platelet aggregation, which is that second step of the platelet activity, and then you can get vasodilation, improving blood flow. Primary indication is intermittent claudication, and we talked about this medication, silostazol, and it being contraindicated for the class in our heart failure patients. If you remove that, you'll see it pop up again when you look back on your slides. Where we mentioned the intermittent claudication, and be careful if the patient's on this drug with another drug interaction, which is why you don't use it in heart failure. So you'll pick it out of the first time you heard it was in the heart failure, but now this is just a little bit more deeper of why it's in the other antiplatelet category. But nonetheless, the same contraindication applies on this slide as it did when we spoke about it in the heart failure slide. Don't use it. It actually increases mortality in heart failure patients. Black box warning for it. So that's when I would know the contraindications for heart failure. Here's your side effects, headaches, diarrhea, arrhythmias. You can have some serious hematological changes like thrombocytopenia or leukopenia, which if you have heart failure, you're not going to use it, so that's absolute contraindication. Active bleeding with all of the antiplatelets, anticoagulants, you don't use any anticoagulant, antiplatelet, whether it's in the other category or one of our main players. Active bleeding, we don't use it. And the silastazole is a major CYP3A4 inhibitor, and we've talked a bunch about some of the other things in that class where you can increase levels of other medications if they're being inhibited also by the CYP3A4 or grapefruit juice as well, to where you can get toxic levels of medications because they're being inhibited from being broken down due to the combination of that medication and inhibiting the enzyme. And there's some specifics there. Strong inhibitors you need to be aware of. The dialtazam, the omeprazole, clarithromycin comes up every time we talk about the CYP3A4 inhibitors. Okay, we're switching gears completely. So just for a couple of minutes, we're going to talk about the classifications of pulmonary embolisms. There's massive, which you're going to have sustained hypotension, pulselessness, or profound bradycardia. Submassive, you have normal blood pressure, so you're normal tensive, but you have some evidence of right ventricular dysfunction or myocardial necrosis. And then you have a low risk PE. There's no hemodynamic compromise, no right ventricular strain, and you have normal biomarkers. And we talked about biomarkers, and I told you there were a whole bunch of them that we look at for our MI patients, such as troponin, among others. Management of your PEs are going to be based on severity. Massive is, we talked about it earlier, get the TPA on board, right? Thrombolysis. You have a clot, it's massive, bust it, or go in for surgery and do a thrombectomy, surgically remove the clot. A submassive, which is defined as normal tensive, but some right ventricular dysfunction, then we're going to do our anticoagulants, which we discussed when they could be used for PE, when we went into each anticoagulant and what it does in the cascade and where it hits. You can consider lytics, you can consider the thrombolytics for a submassive, but it's going to be based on special markers, those biomarkers, and also the amount of ventricular dysfunction, right ventricular specifically dysfunction. And then low risk PE, no surgery, no clot busting, just anticoagulations. For that right ventricular changes, usually that's going to be showing up on echo, and then the markers, the BNP and the troponin. The troponin that I mentioned, but you don't need to know those at this point. And then here is the decision pathway for your therapy, starting with shock evaluation, hypotension, and respiratory failure. Key takeaways: if they have a massive PA or a PE, get your TPA on board. You don't need to know the dosage for it. If there's no features of massive, then look for that RV strain, and I told you how they would do that, or how it would be done. Usually the submassive is going to be heparin or low molecular weight heparin because they're in the hospital, right? You're not waiting 6 to 10 days for warfarin to kick in a submassive PE. And then low risk PE, anticoagulate only, and then the black box warning for all the factor XA inhibitors is if they have a spinal or an epidural hematoma. The most important thing to do in early step evaluation and treatment of PE is to stratify the risk. categorize it so you can figure out what needs to be done. You don't have to start figuring out, run them to a scanner, get imaging, or deciding what anticoagulant to use. First, you want to stratify them based on their signs and symptoms and then decide what the treatment's going to be. And that's just the outline for PE therapy. It's the same information I gave you on the other slides as far as key takeaways for massive TPA or thrombectomy. No massive features. If they have a right ventricular strain, it's a submassive, and then usually that's your heparin because you're in the hospital with a submassive PE. And then low risk is anticoagulation. Okay, so these, what we're showing on this slide is agents to manage bleeding from either an anticoagulant or coagulopathy. Blood transfusion, obviously, you're managing, if you have too much blood loss, you can do transfusion. Cryoprecipitate is rich in fibrinogen and von Willingham's factor and factor VIII. So those are all gonna kind of help you with your bleeding, whether it's from anticoagulation, anticoagulants, or coagulopathies. So cryoprecipitate has the fibrinogen, the von Willingham factor, and factor VIII. We talked about how each of those are important in the clotting cascade or the coagulopathy cascade. Then we mentioned the PCC formulations, Kcentra and profilinin, and then TXA, transaminic acid, and we'll hit that one on the next slide just for a sec, because for the Army folks and some of the other services, we actually are using it in our TC3 protocols, right? For bleeding, we give them an injection of TXA. Blood products is always good for bleeding, right? No matter the cause, coagulopathy, anticoagulants, or some vascular damage, packed red blood cells, platelets, plasma, based on the bleeding source and the underlying medication. If there's bleeding due to a direct oral anticoagulant, PCCs are how you're going to reverse it, which we hit that earlier. TXA, antifibrinolytic reversible complex with plasminogen, prevents conversion to plasmin, stabilizes clot formation, and reduces bleeding. FDA approved heavy menstrual bleeding for the oral version of TXA, and then hemophilia for the IV version, hemophilia related to dental procedures. And then off-label, we talked about it, trauma, associated hemorrhage in all the ambulance services in most cities, large cities, some rural areas are carrying TXA now. It's kind of become standard. It used to be really popular, then it fell down, but now it's back again. And most everybody's embraced it for trauma-associated hemorrhage. It's always been used in obstetric hemorrhage. That's how the medication was developed. And then these other uses and off-label uses were found later, but it was originally for obstetric hemorrhage. Epistaxis, you can use it off-label, nosebleeds, perioperative bleeding control. If there is a history of thromboembolic disease, caution with TXA. It could precipitate thrombosis. Side effects, headache, abdominal pain, back pain. You can get DVTs as a severe side effect, and stroke, pulmonary embolism. TXA is renally cleared, so you obviously have to watch your dosing in renal dysfunction, patients with renal dysfunction. Don't use it in patients with active intravascular clotting or a history of thrombosis unless under specialized guidance or care. Okay, there's about 5 slides on anemia that you can look over, maybe 6 or 8, but they're very straightforward. In anemia, the hard part about anemia is diagnosing it based on, is it megablatic, is it microcytic? So you got to determine, is it due to a folate deficiency, is it due to an iron deficiency? When we talk about it from a Pharm side of the house, since we're not making you diagnose, really is kind of straightforward. If it's B12 deficiency, we give them B12. If it's iron deficiency, we're giving iron. But we will spend about 5 minutes Tuesday before we start the review, talking about the different types of iron, whether we're giving an IV or oral, and the cautions with that, and how we can get after some of the genetic causes of anemia. There's only a couple of things that we can do. So it's a few slides, but it definitely is nothing that you're going to have difficulty picking up with just a once over. If you look at the slides, and then we discuss it briefly on Tuesday, and then we'll definitely have plenty of time, six days from there to get spun up on it before the test. So we'll knock it off there. Like I said, there's a few slides at the end that you want to look over before we meet on Tuesday. I'll hit anemias for 5 minutes. We'll do our review. After this class, probably later this afternoon, you'll get the check on learnings and the memory jogs for this. The memory jogs are already posted in your slide deck, but I'll pull it out like I had the other ones and drop it into the memory jog and check on learnings. And then, as I said, if you're getting after it over the 4 days studying, anchor your